Hi everyone. So in today's video, we're going to be talking about anaphylactic shock. So anaphylactic shock is a systemic type 1 hypersensitive reaction that often has fatal consequences if untreated. The causes are the immune system releases a flood of chemicals that can cause a person to go into shock. So the pathophysiology of anaphylaxis is when an individual, after a re-exposure to an antigen to which they have a specific IgE antibody, this happens because of the re-exposure. So the sensitivity allergen may cross the mast cells or basophil surface-bound allergy-specific IgE, resulting in cellular degranulation as well as a synthesis of mediators. Then binding occurs, and binding happens at the immunoglobulin E, and it binds to the antigen, which provokes the allergic reaction. Then activation occurs, so the antigen bound to IgE activates certain receptors on the mast cell and basophils, which then leads to inflammatory mediator release, which leads to the release of things such as histamine. Once histamine is released, many of the signs and symptoms of anaphylaxis occur, and this happens because histamine binds to its receptors at the H1 receptor mediated pruritus, tachycardia, and bronchospasms can occur. Then prostaglandin D2 mediates bronchospasm and vascular dilation and manifests as anaphylaxis. And leukotriene C4 is converted to LTD4 and LTE, which are the mediators of hypotension and bronchospasm and mucus secretion during anaphylaxis, in addition to acting as a chemotactic signal for eosinophils and neutrophils. That's a lot of information, but pretty much in summary, you have a re-exposure to an allergen which binds at the IgE receptor sites and activates certain receptors on mast and basophil cells, which causes this inflammatory mediator release, leading to histamines releasing and binding at H1 receptors, and that leads to things such as the bronchospasm, vascular dilation, and runny nose. All right, so what are some statistics and that we see worldwide is that 0.05 to 2% of the population is estimated to experience anaphylaxis at some point in life. And it most often happens in young people and females. And of people that go to the hospital, 0.3% do die. And it occurs 1 in 50 Americans, and they've found that 13% of the cases of anaphylaxis occur at hospitals or clinics, 6.4 at a relative or friend's home, 6.1 in the workplace, and 6.1 in restaurants, and 2.6 at school. All right, let's get into the different causes. So these are all things that can cause allergies in people. We have food allergies, medication allergies, insect allergies, latex allergies. The most common type that is triggered in children is food allergies. These are things such as peanuts, tree nuts, fish, shellfish, and milk. When we have medication allergies, these can include antibiotics, aspirin, different over-the-counter pain relievers, also seen with contrast in the hospital for imaging tests. Insect bites can be stings from bees or wasps, hornets, or bites from fire ants. And also people can have latex allergies, which can develop after an exposure to latex. So the clinical manifestations of anaphylaxis is the person is going to experience anxiety. This is usually a feeling of impending doom or fright. You might have heard about this when your teachers or in nursing school, they talked about giving IV blood products or any type of high risk for reaction IV medication. This is usually the first warning sign, the feeling of impending doom or fright. So if you see that in a question on your test or on NCLEX, that is important to keep in mind that a reaction may be coming. So then also you can have skin reactions such as hives, itching, flushing, or pale skin. Shortness of breath, which is from constriction of the airways, a swollen tongue or throat, could also be causing wheezing and trouble breathing. You may also see hypotension, so a low blood pressure that occurs is one of the major symptoms of shock. Tachycardia, because the heart is compensating through pumping faster to try to deliver that blood to the organs within the body. And dizziness. They may feel like they are going to faint. So how can we prevent anaphylactic shock from occurring in patients that are already exposed to an antigen or who have developed antibodies to it? Is to avoid exposure to allergens. So teach patients to avoid foods that they may have allergies to, or certain drugs or certain insect bites. They also use desensitization. If a patient has to receive a drug to which they are allergic, they can prevent the reaction by making sure the patient receives careful desensitization with a gradual increased dose of the antigen or an advanced administration of steroids. So they'll give the steroids before. Monitoring, so they can closely monitor a patient undergoing diagnostic tests that use radioactive contrast media, such as a cardiac catheterization. So complications of anaphylactic shock are respiratory obstruction. The trachea may close up due to severe inflammation, which could result in respiratory obstruction, or they can have systemic vascular collapse, which is sudden loss of blood flow to the brain and other organs, which can cause systemic vascular collapse. So as the nurse, we are going to focus on assessment and diagnostic findings. So because anaphylaxis is primarily a clinically diagnosis, laboratory studies aren't usually required and they're not really helpful. They can do a histamine and trypase assessment if the patient is seen shortly after an episode. This is a plasma histamine or a urinary histamine, metabolites or serum tryptase measurement, which may be helpful in confirming the diagnosis. They can also check 5-hydroxyindoic acetic acid levels. That's a tongue twister. So this is a urinary level that they will measure the amount that is in the urine. They can also test for food allergies. So if they want to identify maybe what is causing these reactions in somebody, they'll take a patient medical history and physical exam, and they will do a puncture of a food allergen specific skin test or an in vitro specific IgE test. And this can be performed, and there's an understanding that both false positives and false negatives may occur during this test. So they pretty much just prick your skin and then look for some type of reaction if you have a reaction that could indicate a possible allergen. Then they can also do testing for medication allergy. So if the patient's history suggests a penicillin allergy, they can do skin testing for this if they find that it might be appropriate. And they can test for suspected insect bites or stings. So if the patient has a history that suggests an insect sting or allergy-specific skin test, they can perform these as well. So medical management. So in treating anaphylactic shock, we want to remove the antigen. So removing the causative antigen, such as discontinuing an antibiotic, this could help to stop the progression of shock. So that is why when you're giving a patient an IV medication and in the question that the patient gets a feeling of impending doom, or you're seeing a rash, you're seeing some type of reaction that could be occurring, the first thing you do is stop the medication. You can also administer other medications that will help to restore vascular tone and provide emergency support, such as basic life functions. You can also do cardiopulmonary resuscitation. If cardiac arrest does occur or respiratory arrest occurs, then you will do CPR. There's also endotracheal intubation or a tracheostomy if you need to establish an airway. And IV lines can be placed to provide access to administering fluids and other medications. So pharmacologic therapy, there are 2 drugs that we use for patients that are having anaphylactic shock, and that is epinephrine. It's given for a vasoconstriction reaction in emergency situations, an immediate injection of 1 to 1,000 aqueous solution, 0.1 to 0.5 milliliters is repeated every 5 to 20 minutes. Then there is Benadryl, which is administered to reverse the effects of histamine, thereby reducing capillary permeability. And also albuterol, if there is a bronchospasm due to a histamine-induced bronchospasm, we can give the patients albuterol. So that's not on the slide. Make sure to add that to your notes. So nursing assessment. We are going to assess for any kind of allergy. This is why when we do our admission assessments, we are asking, do they have any previous reactions to medications? Do they have any allergies that they know of? Because that can help us to prevent these kinds of reactions. We assess the patient's knowledge. So we need to know what the patient's baseline level of understanding to previous reactions and the steps that them and their family can take to reduce these exposures in the future. And also new allergens, when they are identified, we want to advise the patient to either wear or carry identifications that name these specific allergens or antigens. So our nursing diagnoses for patients undergoing anaphylactic shock is impaired gas exchange related to ventilation perfusion imbalance, altered tissue perforation related to decreased blood flow, secondary to vascular disorders due to anaphylactic reaction, inactive breathing patterns related to the swelling of the nasal mucosa wall, acute pain related to gastric irritation, impaired skin integrity related to change in circulation. So these are all different diagnoses you can use when you're coming up with your nursing care plans and goals. So these are our goals for the patient. Client will maintain an effective breathing pattern as evidenced by relaxed breathing at a normal rate and depth in the absence of adventitious breath sounds. The client will demonstrate improved ventilation as evidenced by absence of shortness of breath and respiratory distress. Client will display hypodynamic stability as evidenced by a strong peripheral pulse with a rate of 60 to 100 beats per minute with regular rhythm, systolic BP within 20 of the baseline, urine output greater than 30 milliliters an hour, warm, dry skin, and alert, responsive mental status. The client and significant others will verbalize an understanding of allergic reactions, its prevention and management. Client and significant other will verbalize understanding of need to carry emergency components for intervention, need to inform healthcare providers of allergies, and need to wear a medical alert bracelet or necklace, and the importance of seeking emergency care. So, nursing interventions. We want to monitor the client's airway and assess for sensation of a narrowed airway. Are they having trouble breathing? Assessing, do we hear anything when they breathe in and breathe out? We want to monitor their oxygenation status, so we can do this with arterial blood gas values, or we can just use an O2 sensor. We want to focus on breathing, instruct the client to breathe slow and deeply. Like we said, the first sign you may see is some anxiety, and when people experience anxiety, they're taking those short, like chest breaths, very not deep breaths. So we want to remind the client to be breathing slowly and deeply. Positioning. We want to make sure the client is sitting upright. Any question that you get on an exam that is to improve breathing, positioning is a big one to remember. You want to have the patient sitting up. That is going to be the easiest way to breathe. and it provides the maximum amount of chest expansion when they're sitting up. So if they're in respiratory distress, you want them sitting up. Good way to remember this is if we see a patient in respiratory distress, a lot of times they might be in a tripod stance. So that's like they're sitting up, they have their arms on a table or open, and that's they're trying to really like breathe in. So that's how I always remembered that sitting up helps people breathe in, because when people struggle to breathe, that's the position their body wants to get in because it allows the biggest amount of chest expansion. We want to promote activity, although we do want to encourage adequate rest. We want to make sure to limit activities within the client's tolerance. So of course, we know that we want patients to get up and move in the hospital to increase the blood flow and help with clots and DVTs and things like that. But if they're really having trouble breathing, we don't want to encourage too much activity because that's going to require more oxygen for their body. We can also look at hemodynamic parameters, so monitor the client's central venous pressure, pulmonary artery diastolic pressure, pulmonary capillary wedge pressure, and cardiac output and cardiac index. A little bit of a tongue twister. We also want to monitor urine output. So the renal system compensates for low blood pressure by retaining water, and decreased urine output is a classic sign of inadequate renal perfusion. So we want to make sure that we have that 30 milliliters per hour of urine output. If not, that is a sign of inadequate renal perfusion. So as the nurse, our evaluation is going to look at client maintained an effective breathing pattern, they demonstrated improved ventilation, they displayed hemodynamic stability, they verbalized understanding of allergic reactions and prevention and management, and they verbalized understanding of the need for emergency components for intervention, need to inform healthcare providers of allergies, wear medical bracelets, and the importance of seeking emergency care. So our evaluation is really based on our diagnosis and interventions. This may not be what your evaluation is. You can take certain interventions, maybe they don't work. So now our evaluation is the client hasn't maintained effective breathing, so now we're going to do something else. Our interventions are going to change based on our evaluation, but these are just some suggestions. So discharge and home care guidelines. So we want to teach the patient about emergency medications. We want to offer these medications to them. So they may have a prescription for an EpiPen, and we want, or maybe an albuterol inhaler, just so they have some tools if the crisis does reoccur. And we want to assist the client and family to identify factors that may lead to a crisis. So this could be, does everyone understand the type of foods that this patient is allergic to, that they shouldn't be around those foods? Do they understand that, say for example, it's a peanut allergy, that if they're on a plane and somebody opens up a bag of peanuts, that could stimulate a anaphylaxis reaction? It's not necessarily that the patient needs to eat peanuts. So just teaching like this, because people don't understand this stuff normally, and that is why nurses come in as educators to help them understand and inevitably save someone's life, because who wants to go in an anaphylactic reaction on a plane? That would be horrible. So these are important things to know. So then our documentation. We are going to include our assessment findings of the respiratory rate, the character of the breath sounds, what did they sound like, the quality of the breath that the patient is taking, the frequency, amount, and appearance of secretions, the presence of any cyanosis, laboratory findings, and mental status. We also want to indicate any conditions that may interfere with oxygen supply. We want to include the pulse, the blood pressure. We want to document the client's description of pain, evaluation or expectations of pain management, and what they identify as an acceptable level of pain. We want to indicate prior medication use. We want to indicate our plan of care, specific interventions, who's involved in planning, our teaching plan, the client's responses to the treatment, teaching, and actions performed. We want to indicate our progress towards the desired outcome, what modifications we may have made to this plan, and the long-term needs of the patient. All right, so that is it for this video on anaphylactic shock. If you guys like this video, make make sure to subscribe to the channel and give this video a thumbs up. And that's all. Thank you. Bye.